Good morning, everybody. In the last class, we have talked about actually the various surgeries we do for cataract. So the first and foremost, which used to which has ruled actually the era of cataract surgery for nearly about a century, is intracapsular cataract extraction. And later on, we started actually extracapsular cataract extraction. And under extracapsular cataract extraction, you have a conventional extracapsular cataract extraction, small incision cataract surgery, PHACO emulsification, micro-incisional cataract surgery, and femtosecond laser assisted cataract surgery. Okay. To recapitulate actually what was said in the last class. So the intracapsular cataract extraction, actually it is, what we do there is, we remove the nucleus in toto. That is anterior capsule, the lens and nucleus and cortical matter, and also the posterior capsule in toto, leaving actually the eye highly hypermetropic. Okay, so the patient will have to be rehabilitated immediately after the surgery with phakic glasses. Otherwise, the patient will be able to see up to say 1 meter distance, not more than that. And the near vision will definitely be hampered because of actually the lens is removed and the accommodation is knocked off. Okay, so the problems with phakic glasses also I have already mentioned. The phakic glasses, they are plus 12 or plus 12, plus 10, plus 12 power, is they are convex lenses. So these people, suppose if it is a uniocular aphakia, the patient definitely will have a diplopia because there will be magnification of around 33% of the image by wearing the phakic glasses. The other eye being normal, these two images, they cannot fuse at the cortical level, and that gives rise to diplopia. And there will be spherical and chromatic aberrations which have been actually telling, such as a roving ring scotoma and pincushion effect, jock-in-box phenomenon. All these things will occur. Finally, to wear actually thick coke bottom type of glasses is a cosmetic blemish. So that's the reason the people actually, they were not very happy with the phakic glasses. Suppose if it is a binocular aphakia, so then the patients may get adjusted to this as early as possible. But uniocular aphakia, there was always a problem, and we started searching for other alternatives for cataract surgery. And we, after 1980, I think we have started doing actually the extracapsular cataract extraction. So extracapsular cataract extraction, I have already told you, actually it is, we make a circular cut in the anterior capsule, the nucleus is expressed out, and the cortical matter is aspirated with irrigation and aspiration cannula. And the posterior capsule, which is left behind, actually, on that, we keep actually intraocular lens, an artificial, clear intraocular lens, so that the patient's vision will be better in the post-operative period. Okay, so the incision normally here actually it is 10 o'clock to 2 o'clock, whereas in case of a small intracapsular cataract extraction from 9:30 o'clock to 2:30 o'clock. So there the incision is small, so naturally the astigmates and post-operative surgery-induced astigmates will be more in case of intracapsular cataract extraction. Since there is no posterior capsule, there is a problem, a chance of actually vitreous disturbances such as a vitreous touch syndrome, pupillary block, and vitreous may come into the this thing, it's an incision and incisional site, and it may give rise to actually the closure of the wound problems and giving rise to an irregular astigmatism, all these things. And the patient will have the trouble all through the life actually if it is not, if the proper vitrectomy was not done. Okay, and the next actually the other problems I have told you about the phakic glasses and the post-operative vitreous disturbances and post-operative retinal detachment and post-operative incidence of actually the diabetic neovascularization and diabetic retinopathy is more common actually in case of intracapsular cataract extraction when compared to the extracapsular cataract extraction. In extracapsular cataract extraction, what we do is we separate the lids with the speculum, universal speculum, and superior rectus suture was put so as to keep actually the lobe in the downward gaze. and fornix-based conjunctival flap is taken. Tenon's fascia is cleaned with Tuke's knife, and an incision with a 15 blade is a groove or gutter is made with from 10 o'clock to 2 o'clock. And at 12 o'clock, we enter actually the anterior chamber with 11 blade. The moment you enter the anterior chamber, the chamber collapses. There is because the aqueous it comes out. Okay, so you will have to reform the anterior chamber with methyl cellulose or any viscoelastic substance you have, so that all your acrobatics which you do actually in the anterior chamber, they are not going to endanger the corneal endothelium, thereby resulting in corneal decompensation. Okay, then you do actually the capsulotomy. The capsulotomy is, as I have already told you, there are 3 types. One is a can opener technique, and second one is an envelope technique, and third one is a continuous curvilinear capsular excess. So can opener technique, normally we make cuts, radial cuts in the periphery of the lens, nearly about 50, and we try to coalesce them, and later on we remove actually the capsule. Okay. In case of hypermature cataract and mature cataract, actually we make, normally we prefer to do, sometimes we do this envelope technique. So we make a straight line in the upper half of, upper 1/3 of actually the lens from 10 o'clock to 2 o'clock. And we perform all the surgery, remove the nucleus and aspirate actually the cortical matter and everything. And then we put in an eye wire and then we rip off the remaining anterior capsule. In case of continuous curvilinear capsular excess, we make actually a circular hole in the anterior capsule by elevating some flap of anterior capsule with your capsulotomy, or with actually a 26 gauge needle bent at the tip and also hub. And we have actually capsular excess forceps also. So with any of these instruments, actually we try to do actually capsular excess. Capsular excess is the best technique for cataract surgery because the patient, the lens we introduce, it stays in the bag in the normal anatomical position of the lens. Okay, so that's the advantage. So after doing a capsulotomy, what we do in case of extracapsular cataract extraction is we give pressure and counter pressure. After doing hydrodissection, hydrodelineation, as these things, we make a pressure and counter pressure at 6 o'clock and at 12 o'clock with a lens spatula and a lens hook, and express the nucleus after extending the corneoscleral incision with a corneal scissors. Okay. So then the remaining cortical matter, we try to do a perfect cortical cleanup with irrigation and aspiration cannula, and the lens is put, and there we put the sutures in case of extracapsular cataract extraction, say around 5 sutures, one at 12 o'clock, one on either ends, and another 2 in between the 12 o'clock suture and peripheral suture. So the sutures must be radial and equidistant, so that the patient will have minimal astigmatism in the postoperative period. Okay, so the conjunctiva is spread over the incisional line, and we inject actually leukodron and gentamicin, and we close the eye and put the patch and see the case after 24 hours. Okay, so next we have actually small incision cataract surgery. Small incision cataract surgery, the lids are separated as usual with a universalized speculum, and the superior rectus suture is put so as to have steadiness of the globe in the downward gaze, and you will have enough space in the superior fornix for all your maneuvers. And then we make actually a fornix-based actually conjunctival flap, which you have already seen in the video, and we make a corneoscleral tunnel. So initially the incision, either it can be straight or it can be frown shape or chevron shape. Okay, so you have seen actually the frown shape or chevron shape the incision. So then we make actually a corneoscleral tunnel with a crescent blade. We go into 1 to 2 millimeters into the clear cornea. Suppose if there is a premature entry, we leave that place and we try to do corneoscleral tunnel from another place. Okay, and then after doing that, actually with a crescent blade, you enter actually at 12 o'clock position, and you make with the side port blade, we make actually an entry into the at about 9 o'clock with the entry with a side port incision also. So you do again a capsulotomy. We try to do most of the maneuvers from the side port only, so as to leave actually the main incision virgin. okay? So it will not actually be lax. In case if you do all the maneuvers through the primary incision, the primary incision may become actually very lax, and there can be the post-operative complications. So there's a reason with side port we try to do it. We do the capsulotomy, and we do actually hydrodissection. Hydrodissection is done by injecting some aliquots of Pringer lactate or BSS salt solution underneath the anterior capsule. So the idea of doing actually the hydrodissection is to separate the corticonuclear mass from the posterior capsule. So in small incision cataract surgery and also in PHACO emulsification, it's a must that you should do a hydrodissection very well. The nucleus must be free from the posterior capsule and also the anterior capsule. So you will have to, you should be able to turn the nucleus in the bag, okay? So after doing hydrodissection, we do hydrodelineation. We inject actually small amounts of BSS salt solution again between the nucleus and epinucleus so as to reduce the size of the nucleus. Okay. So after doing actually this thing, we try to bring the nucleus into the anterior chamber by dialing the nucleus. And the nucleus is delivered by different methods. One is irrigating vectis, and second one is PHACO fracture and PHACO sandwich technique. And you have actually fish hook technique and Blumenthal technique. All these techniques are there for removing the nucleus from the anterior chamber outside. And later on, whatever cortical matter is left behind, actually it will be aspirated with an irrigation and aspiration cannula. And in case of small incision cataract surgery, you need not do put any suture normally. Suppose if you think actually the main incision is lax and there can be some leakage, in such cases you can put one suture at follow clock position or an infinite suture, which takes guard of the problem which may face actually in the post-operative period. And the side port is hydrated so that there won't be any leakage from the side port. And we inject similarly, we try to spread the conjunctiva over the incisional line, and we inject corticosteroid along with an antibiotic, gentamicin or amikacin or whatever it is, and dexamethasone, and we close the wound and we see the patient the next day. So the next one we have is PHACO emulsification, so which I'm going to show you now. Okay. PHACO emulsification is a preferred technique nowadays, and now we try to do actually PHACO emulsification under topical anesthesia. So we don't, sometimes some surgeons, they prefer actually giving a, they prefer actually giving a cerebral bar anesthesia. So topical anesthesia, we use the drugs either surfacaine or methacaine or paracaine or xylocaine 4%. We inject one drop at 4 minutes interval 4 times per day, some an hour prior to the surgery, and then we do the PHACO surgery. So similarly, the eye is separated, and later on we put actually the superior rectus suture. A fornix-based conjunctival flap is taken. Tenon's fascia can be cleared with actually Tooth's knife in case if you want to do a corneous clearance incision. Suppose if it's a clear corneal incision, there is no need for it. Okay, and you make actually 2.8 millimeters into 3.2 millimeters incision at fellow clock with your blade, keratome, and the side ports are given, 2 side ports. And then we actually put in actually the inject the reform the anterior chamber with viscoelastic material, methyl cellulose or chondroitin sulfate or sodium hyaluronate, whatever it is. So we inject it and we reform the anterior chamber. And later on, actually, we put in, after doing a capsulotomy, capsulotomy must be done, and capsulotomy must be a capsulorhexis. Continuous curvilinear capsulorhexis in PHACO emulsification and small incision cataract surgery. So after doing a capsulorhexis, the anterior capsule is removed, and then you do hydrodissection to separate actually corticonuclear mass from the posterior capsule. And hydrodelineation is also done to reduce actually the nuclear mass. Okay, and then we pass in a PHACO probe, a PHACO emulsifier. PHACO emulsifier, it contains actually a 1 millimeter titanium needle, which acts by piezoelectric effect and rotates in the longitudinal axis at a speed of 40,000 revolutions per second. So this actually emulsifies the nucleus. Okay, there are different types of actual methods of dealing with the nucleus, such as PHACO chop, divide and conquer, and direct PHACO chop, chip and flip technique, woodcutter's technique. Likewise, there are a lot of techniques actually, depending upon surgeon with which he is well conversant. You will try to do the particular chop. Okay, and after doing actually the managing the nucleus, we try to aspirate the cortical matter either with PHACO aspiration or by an irrigation aspiration cannula, two-way irrigation and aspiration cannula. And then we put in a foldable IOL through the 2.8 millimeters or 3.2 millimeters incision with an injector and dilate into the place. So that's how actually we do it. And later on we inject routinely the xylocaine and also, sorry, not xylocaine, it's an antibiotic along with steroids, and put the patch, and we can see the case next day. So now I'm going to show you actually some surgeries of PHACO emulsification. This is an animation of PHACO surgery. That's lens, cornea, iris, pupil. So the lids are separated with universal speculum. So this is a clear corneal incision with a keratoma of 2.8, and side port is also given. And we inject actually the viscoelastic materials to reform the anterior chamber. And a capsulotomy is being made, a capsular excess. So that's not actually, that's only, this is an animation. That's the reason we are showing like this. And so this is hydrodissection. This is doing actually PHACO emulsification. Now it is aspiration. So the lens is being aspirated. Nucleus is being aspirated. An intraocular lens is put. So there's a foldable intraocular lens, and that's how actually the surgery is over. Okay. So now this is actually the live surgery of PHACO. So it is done under topical anesthesia. As I told you, these are the surgeries which I have actually downloaded from the Google, as we never had any facility for recording our own surgeries. So a side port is being done with a side port blade. This is a 15 degrees angle will be there. And this is the drug which is going to be injected is TRYPAN blue. It stains actually the anterior capsule, and doing capsular excess becomes easy. After staining it, actually we wash it out with saline, and then again we inject the viscoelastic material, sodium hyaluronate, or this methyl cellulose over the cornea also, and the side port actually being given. And this is the main entry, 2.8 millimeters. Incision, clear corneal incision is being made, and these incisions, they are actually self-healing. So capsular access, we lift the anterior capsule, okay, by making a cut like that. And then actually we try to rotate it in a circular fashion. So there's a capsular access forceps which is holding. And you can see actually the anterior capsule and behind actually the nucleus and also the cortical matter. So that's how actually we do a rhexis. So the anticapsule is removed. And again, we inject some amount of viscoelastic material to reform the anterior chamber sometimes. And now actually we are doing, what he's doing is a hydrodissection. So now actually PHACO emulsification of the nucleus is being done. As I told you, it's a titanium needle of 1 millimeter diameter, and which acts by piezoelectric effect in the longitudinal axis. It vibrates with a revolution of 40,000 vibrations per second. And there are different techniques actually which we use for managing the nucleus. This is actually a divide and conquer technique. So he has already broken it into 2 pieces, and now actually the further 2 more pieces will be done. And so we rotate the nucleus. That's the reason actually why we do the hydrodissection, so that it will be separate from the posterior capsule and the bag will be intact. And that's how actually we do it. And now it is PHACO aspiration is being done. So we eat away actually the nuclear fragments with the PHACO probe. So cortical wash will be done going through the side port to remove the 12 o'clock cortical matter, because it becomes difficult to go through the main incision and remove the 12 o'clock cortical matter unless we have a J-shaped cannula. So this is an irrigation, 2-way irrigation and aspiration cannula. In the examinations, we ask you after showing this instrument what exactly it is. You will have to name the instrument and also tell the various uses of it. So the cortical matter is being aspirated. As you see that, we catch hold of its beginning by going underneath the iris. That's how we do it. So now you can see actually the capsular access margin also, okay. So the last piece of the cortical matter which is left is being aspirated, and now again that's also being done. And again the chamber is reformed with viscoelastic material, and this is actually cartridge IOL injector, okay. We load actually the IOL inside and fold it. Okay, then we inject it. Okay, that's how actually we place in a foldable IOL. And the remaining viscoelastic material which is left behind over the lens and also in the anterior chamber and also between the lens and also the posterior capsule will have to be aspirated. Otherwise, this viscoelastic chamber, which is thick, it's going to clog actually the trabecular meshwork, and it may give rise to actually a raised intraocular pressure in the postoperative period. So, thorough irrigation, and we reform the anterior chamber with this thing. And you inject finally gentamicin along with decadron and close the eye, and we can see the case actually after 24 hours. And sometimes actually we see the case after, suppose if we do it in the morning, and you can remove the patch in the evening and put nowadays actually what we are doing is we are giving dark glasses to the people immediately after surgery, and we ask them to go home, and we request them actually to stay put without any strain or anything for a few hours, and later on they can do their routine work without any problem. Okay, so this is actually a PHACO emulsification procedure which we do in case of cataract surgery. And there are two more procedures which we have. First is actually a micro incision cataract surgery. Here actually the incision is less than 2 millimeters. Okay, almost the postoperative cataract surgery induced astigmatism is nil in these cases. Actually, this is first done by Dr. Amar Agarwal of Chennai, and the fact that we make a small incision through the small incision, we have a micro PHACO probes also, with which actually we do the PHACO emulsification completely, and remove the nucleus, aspiration of the nucleus, and everything will be done. Aspiration of the cortical matter, a perfect cortical cleanup, as I said, it will be done. And later on, a rollable IOL actually will be put in these cases. Okay, so through the 2 millimeters incision, a rollable IOL, which is actually manufactured by the material hydrogel. Hydrogel is the material which we manufacture a rollable IOL. Okay, and next we have a femtosecond laser assisted cataract surgery. So here actually with the femtosecond laser, this is the recent advent in case of cataract surgery, and if suppose if one can afford, this is actually the best method. It costs around $1.50,000. Some people they do it for a lesser amount also. And here actually there are certain steps which we do with the femtosecond laser, and there are certain steps which we do later on under the microscope. So the patient is after giving topical anesthesia or peribulbar anesthesia or whatever it is. So we separate the lids and we keep the patient underneath the femtosecond laser. Initially, the first step done is actually capsular excess. Okay, so the capsular excess will be done, and capsular excess done by femtosecond laser is accurate and well-defined, centralized one. Okay, and this is a very good type of actually capsular excess with which we can do with the femtosecond laser rather than manually doing that. Okay, and next actually the corneoscleral tunnel can also be done by your femtosecond laser, and with the corneoscleral tunnel done by actually femtosecond laser is more tight, and it gives little problems such as leakage in the postoperative period. Okay, and dealing the nucleus with femtosecond laser also is has got advantages. We can reduce actually the PHACO energy. We can the PHACO energy which we use actually for doing the managing the nucleus and everything can be reduced. We need not do it because this PHACO fragmentation can be done with femtosecond laser. And then we shift the patient from the femtosecond laser onto the microscope. So here we separate again the corticoscleral tunnel with a fine iris depositor, and then we enter with the PHACO probe, and we aspirate actually the PHACO fragments, which are already done by a femtosecond laser. And aspiration of the cortical matter can be done with either a PHACO aspiration or with a two-way irrigation and aspiration cannula. And then we put in actually a foldable hair wire. So that's how actually we do a case of femtosecond laser assisted cataract surgery. Okay, so I'll show you some more videos actually, which gives you a mental idea about how we do the surgeries again, and start with intracapsular cataract extraction. This is intracapsular cataract extraction. There is some problem in opening it. Just wait. Outlet console extra videos పెట్టాం కదా, అది వాయిస్ కూడా ఉన్నట్లయితే పెట్టేసి, వాయిస్ ఉంది కదా. తర్వాత మిగతా వస్తాయి కదా, అలాగా దాన్ని అక్కడ పెట్టు.
Example of a planned intracap that Dr. Colder is doing, who was at the University of Iowa, and this was probably done in the early 80s. You can see that this patient has a keyhole pupil, and the surgery is being done from a superior approach. This initial prudomy is done using a combination of the 0.12 forceps for countertraction and these sharp Westcott scissors, or Belody scissors. Here the gill knife is used to remove some episcleral tissue from the limbus, and bipolar electrocautery is used to achieve hemostasis. This is a number 64 beaver blade, which is used to make a groove along the limbus, which is used as a mark for the scissors when the eye is opened. This knife is rolled around to make this groove. The cord length is about 12 millimeters. It's almost 360 degrees around. Here Dr. Colder is using a number 75 blade to enter the anterior chamber. Today we'd probably use a keratome for this step. These are some scissors known as Castro Viejo scissors, which follow the groove to make the incision. These come in a version to the left and a version to the right. Here a vicryl safety suture is placed. Just in case there's a choroidal hemorrhage at the time of expression of this lens.
I think this patient here has
the remainder of the incision is made on either side.
incision is being extended.
And additional sutures placed just in the anterior aspect of the wound. And this is used to lift up the cornea later, as you'll see. Now you can see that this requires an assistant. An assistant has a special iris retractor, which is coming in from the left. Dr. Colder has the cryoprobe, which is coming in from the right. And the assistant is also lifting up on the cornea to give exposure. Dr. Colder is using a Wexel sponge to dry off the anterior surface of the lens. This often has to be done several times to remove the aqueous from the anterior surface of the lens to allow the cryoprobe to firmly adhere to the crystalline lens. Here Dr. Colder has applied the cryoprobe, and you can see the white tip, the ice ball is attached, but then came off of the lens, probably because the lens was too wet. And so the Wexel sponges are applied again to get the anterior surface of the lens dry. Here, once again, the cryoprobe is attached to the crystalline lens. Foot is on the pedal. Care is taken that the freezing does not extend to the iris or to the cornea. The lens is gently rocked free. You can see the stress on the anterior capsule as Dr. Colder gently removes this lens, which is pulled free from the eye. Capsule and all, so it's an intracapsular procedure because both the capsule and the lens were removed. Now it's simply a matter of suturing the eye closed. The safety suture is closed first, and then Dr. Colder would often place a couple more vicryls to reapproximate the wound before placing his long running 10-0 suture.
So since the incision is very long, very last one, we put nearly about say some 6 to 7 sutures. So 10-0 nylon is the one that normally we use. You can use actually 80 silk or whatever it is.
This looks like another safety suture going in here. But eventually he places his running 10-0 after placing these safeties, just to get everything reapproximated and to keep it safe in case he could have a choroidal hemorrhage. In this case, Dr. Colder did not place a lens. It was common early on to use contact lenses for rehabilitation. So in this case, this patient did not receive an intraocular lens. Here you can see the running 10-0 has been placed. It's a beautiful closure. Dr. Colder will readjust the tension on this running suture a little bit. First, filling the anterior chamber, in this case most likely with BSS, and then the running suture is reapproximated. Look how beautifully all of these segments match each other in size. And so now this is tied down, and the surgery is essentially over. The conjunctiva is reapproximated, although it's not shown. Most likely it was reapproximated using one of the 7-0 vicryl fragments.
So there is edema actually in this particular case. And as I said, actually the idea, what we do is actually for rehabilitation of visual rehabilitation of these patients is, one is FAK glasses. Suppose if it is a uniocular aphakia, you can as well try the contact lenses. So the contact lenses have definitely ameliorated most of the problems associated with the aphakic glasses. There won't be actually a reduced field effect. There won't be roving scotoma, and chromatic and spherical aberrations which are seen with the actual aphakic glasses. They are not seen, and there won't be diplopia, because in case of aphakic glasses, So what we see is actually in case of with contact lenses, the magnification of the image will be around 7%. So the patient well tolerates and there won't be diplopia in these cases. Okay. And next we go on to some of the video. Let us see actually ECC extra.
Dear young colleague, this is how you put a superior rectus bridle suture to turn the eyeball a little downward. In this video, I am going to show ECC, extracapsular cataract extraction. And this is a very safe surgery and you can give very good vision to your patients. This is how you incise the conjunctiva. We must remember that the conjunctiva is inserted very close to the limbus and the Tennant's capsule a little behind. So I'm going to incise the conjunctiva first. One blade of the corneoscleral suture goes behind the conjunctiva and one blade remains outside and you cut, and thus this is Tennant's capsule. Incise the Tennant's now and expose the sclera. That's it. Now you incise the Tennant's capsule. Now if this Tennant gets exposed, sometimes it can cause granuloma. So trim a little bit of Tennant's capsule, about 1 millimeter or 1.5 millimeter. Now learn to be ambidextrous. Learn to use both of your hands. Now I am going to hold the Tennant's with my right hand and use my left hand to do this on the right side corner. That's it. Now we have to do wet field cautery, a very mild cautery. Just touch on the blood vessels and never cause any charring of the sclera. Never cause any burn to the sclera. Just touch on the blood vessels and make the area clean. Now this is how you plan the incision of SICS, a frown incision. But we're going to do ECC, we're going to cut along the limbus, like this. Just 1 or 1.5 millimeter behind the limbus. This is how you incise. Be very gentle. Go about 1/3 thickness or half thickness of the sclera. If you are very superficial, you can again use your 50 number BP blade and go a little deeper. Now you take the crescent blade and make a very short tunnel. By this surgery, you are going to learn how to make tunnel of SICS. In this case, we are going to make a very short tunnel from this incision to about 1 millimeter into clear cornea. There it is. Just engage the end of the crescent blade and make this kind of movement and make a very small tunnel. So this is going to be a two-plane incision, one vertical and then horizontal to some distance, only a little bit into clear cornea. That's it. Your incision is made. Yes. So now you make a side port. This is how you make a side port. Oblique entry into the antechamber. And now inject viscoelastic substance. Inject HPMC into the antechamber. Fill the antechamber with viscoelastic substance. Wash the cornea. Take a 26 case bent cystitome and do can opener capsulotomy like this. Just give horizontal cuts, adjoining horizontal cuts.
This is can opener technique.
We have done so many surgeries with this can opener technique, and one of my senior colleague, Dr. Ramesh Turairajan, said that with this kind of capsulotomy, we have never seen PCO. Probably because this anterior capsule and posterior capsule get stuck, and it prevents migration of epithelial cells onto the posterior capsule. Now, this is how you enter into the antechamber through the main incision, and just cut half of this main incision. Other half will cut later. Now do hydrodissection in this way. Inject fluid just underneath the anterior capsule and depress the nucleus a little bit. Go to the other side, hydrate it, and depress the nucleus. Now inject viscoelastic substance. Inject HPMC. Take a Sinskey hook and rotate the nucleus. As you rotate, elevate the superior equator and go underneath the nucleus and rotate it. It will come in front of the iris. Now inject viscoelastic substance both above, both in front and behind this nucleus, behind this cataract. And now cut the other half of the main incision. We should not take any patient who has respiratory distress, who has cough, etc. for this kind of surgery. Because if the patient coughs, there can be raised intraocular pressure and a lot of unintended things can happen. Now this is a PHACO. You can make it. It has got 2 bends. I got it from Lahan Eye Hospital and we learned to make it ourselves. If you come to me, I can teach you how to make this PHACO. And very safely you can deliver the nucleus with the PHACO like this. Now we are going to inject viscoelastic substance and put 2 temporary sutures. We are going to remove these sutures after just before implantation of intraocular lens. This is how you put the suture. We're going to see this again. This suture, learning to suture on human eye is so important, because if a perforated injury, perforated corneal injury comes, you have to suture it very nicely. And after you put suture, you aspirate the cortical matter. Go through the side ports. We have made one more side port on the left side. Now cortical matter from the left side has been removed. Now you go through the side port on the left side and remove the cortical matter from the right side. Pupil has become small, and we have to be very cautious when the pupil becomes small. But in most of the cases, pupil will be dilated and you will be able to see the anterior capsular margin. That's it. The cortical matter has been cleaned. This is I am checking whether cortical matter is cleaned all around or not. Now I inject viscoelastic substance, SPMC. We can see that the posterior capsule is intact, and we can put an IOL safely in the sulcus. Now is the time to implant the intraocular lens. We cut the 2 temporary sutures. Now implant the IOL. Just implant the IOL under the iris. This is a PMMA IOL. You cannot see the capsular margin, so just implant it behind the iris. It is probably going to the sulcus. When we implant an IOL in the sulcus, it may be a little decentered. But this is a 6 mm optic intraocular lens, and the patient will get fairly good vision even if the IOL is decentered a little bit in case of sulcus fixation. But we are going to learn very soon how to implant an intraocular lens in the capsular bag. And this is how we put the sutures: 1, 2, and 3 loops. Pull this, make this knot of optimum tightness. Then one more loop, pull, then one more loop. So this is the first suture. This is the second one. The suture should be radial. The second suture is not exactly radial. It should be more perfect. It is a little oblique. 3 loops.
We do actually
Pull,
conventional cataract surgery. It is little
make the knot of optimum tightness.
Actually a side port, and we make
That is how you lock the suture.
black portion only, and the rest of the things actually they are now
One.
the same.
And another one. So 3, 1 on. Cut, trim this, and this is how you bury the knot.
Show you about 2 more videos, and later on we are going to talk
Just
about the complications.
push the knot inside the tissue.
And also the small.
The patient will not get any irritation.
Bye. Any doubts? వీళ్ళేంటి వీడియో నాట్ ప్లేయింగ్ సార్ అని ఎప్పుడు వచ్చింది నేను చూశాను. ఏం చేయడం నేను 10:30 AM అంటే మొత్తం వీడియోస్ అన్ని చూపించినవన్నీ 10:30 తర్వాత కనబడలేదు. రిపీట్ చేసి